dysmenorrhea has both a potentially a uterine component and a more general pelvic pain component. I believe it's important to try to separate out the uterine component from the pelvic pain component, not just from a scientific basis, but also because the main therapeutic effect of both Lupron and elagolix is on dysmenorrhea. If these medicines are actually treating uterine pain rather than endometriosis pain, I think that would be a significant differential. So I guess my question is, do we have any way, short of questioning the patient about do you have uterine cramps with a menstrual flow, is there any way to separate out dysmenorrhea coming from the uterus versus dysmenorrhea coming from endometriosis in the pelvis?
Can I just ask one clarifying thing? Because adenomyosis could muddy the picture here, which is common and it's comorbid in a lot of patients.
It is, and but that's uterine also in a sense.
Saying Lupron would be expected to affect that.
And if you do the sonogram, you can identify that the patient has adenomyosis very easily. So
well, I'm stuck on the clinical symptom of dysmenorrhea. How do you differentiate uterine versus pelvic source? Because that's an important question for therapeutics.
Let me approach Frankling's paper real quickly. For those of you who think Frankling's paper showed that Lupron can help you diagnose endometriosis, that statistically significant thing he had, the statistically significant observation Franklin had looking at Lupron and pain was comparing Lupron to placebo. Okay? If you read that first abstract, Lupron to placebo. If you dig inside the paper and find Lupron in patients who did not have endometriosis versus Lupron who had no endometriosis, 10% difference, p-value is 0.7. Lupron works for all pain, whether there is or is not endometriosis in that paper.
Well, yeah, and
it's irrelevant. Lupron works for pain, and it looks like it's all estrogen-sensitive pain. It is nonspecific in spite of all the stuff that came out from ACOG.
That's why it might be really important to have a screening tool or a diagnostic that you can use to follow patients that are on therapies that doesn't require an invasive approach.
But I have to add, I think that was a great question. I'd like to add as a clinician, there is laterality also as a component to the uterine pain. Uterine pain is, as a clinician, remind of a more crampy pain where the other pain is sustained is detached from bleeding. A sustained pain usually may have some laterality, even radiation to leg or other parts of the elements that's been discussed in my clinical observation or the way I process things.
Well, in my clinical observation, uterine pain seems to radiate to the lower back, down the front of the legs, and up towards the umbilicus. I mean, those are crude, measurements to ask a patient about, but many times they will say, yeah, I have those things, and for me, that kind of points to the uterus more than endometriosis. But
it's difficult to.
It is, but it's an important
question to Linda Griffith. What makes your setup or the chip environment, synthetic basal membrane style, extracellular membrane style environment different than Bullen's environment? As to, if I believe, she said they developed a gland besides stroma. What is the difference that the media that he uses to get the gland to be produced? Is it the technique or the environment?
Sorry, I don't know what you're asking. The comparison to which?
I do not know what kind of environment does Dr. Bullen use? Do you have an idea?
He's actually producing uterine cells from induced pluripotent stem cells. So the kind that if you took the patient's stem cells and put them in culture and you make them into a pluripotent stem, take their fibroblasts, make a pluripotent stem cell and induce them in. When you do that, a lot of emerging ideas about how you can use those to study disease. I think he's proposing that those could be used for therapeutics. You have to go through a whole lot of things to kind of prove that they're all the way differentiated to an adult version of any of these cells. That's true with all iPS cell derived. So his have a lot of the markers. They're from stem cells and they're the patient cells, but they wouldn't necessarily have all the epigenetic markers that a patient has. I take patient cells, so endometrial biopsies, where it is endometrium by all the standards we would have, and then say this captures things that happen to the patient. So she's got all these kind of dysregulations that have been discussed all day today by the folks up here on the stage with me and others. And can we learn from all the things that happened to that patient, whether it was environmental toxicants or inflammation or whatever, can we learn about the nature of her cells? So I'm looking at patient, that capture the patient's entire experience, whereas he's making them out of iPS cells, which would then lose most of the epigenetic changes that are hallmarks of the disease. Two different applications, though,
Right.
because he wants to use them for regenerative medicine.
Just one comment from clinical perspective. We all come to the idea it's the fibrosis that's the evil part of the whole
Yep.
endometriosis progression. It's the fibrosis that gets hardened and becomes leads to organ dysfunction. So is there a way of measuring glands versus stromal component and that mesenchymal?
We
that
could
is
measure in
estrogen
our
sensitive in a way that really designates the aggressiveness of the clinical, maybe symptomatology too, realistically speaking.
So
Because
in
it's
the
not
in
the
vitro
gland
model.
really, it's the
Yeah.
it's the reaction to the gland's presence or the whole fight going on there that brings that fibrosis and almost ossifying the tissues around it becomes a frozen pelvis in the end, Not every lesion goes to that direction, not at all. Only some group goes aggressively, and by some reason they are all under medical treatment for 10 years, 15 years, non-stop. Everything is given to these patients. Somehow their periods are not there, their ovulation is not there, but their disease is going on and on and on.
So this is why we want to model it. We can measure fibrosis, and you can certainly measure it by using second harmonics in the exact kind of system I have. And we've done that. I didn't show you that data today. But progression to fibrosis through repeated cycling, repeated recruitment of immune cells and inflammation is something that exactly what we want to study. I didn't show that today, but clearly trying to discern how you progress down that path versus others is a point of trying to build these kind of models, and why I hope we can make them simple enough that we could get them out into the community so that Ozgi and you and everybody else could use them. So you could definitely do it in the in vitro model. I don't know how you look at it in vivo, except by the methods others have discussed.
I have a question for Katie Burns. Katie, over here.
Yes, sure.
Fabulous talk.
Thank
It's
you.
a technical question. Have you tested your system with anti-ERA and anti-ERB and anti-GP30 to see which pathway of estrogen this is going down?
Not yet.
You should.
I know.
My other question
But thank you, yes.
for Ozgi is when you inoculate baboons, you have to inoculate them twice in order to get the endometriosis to take. Does that give us any clue about human endometriosis and how it's established?
Well, I guess in humans, of course, it's constant. So one thing with the baboon model is that we overpower the system. We overpower the immune system, essentially any of the clearing mechanisms. You're putting in menstrual tissue at each time point that probably the animal would not see in a lifetime. And we do that purposely to, they're expensive models and we want to really induce the disease. I think part of that is what we found is that, again, as other people talked about, is that if you follow these animals over time, they're always building new lesions. And they will only build them as long as they're cycling. If you over-ectomize the animals and just even give them estrogen, the lesions disappear over time. So it's a seeding mechanism, I think, that's really important.
I had a question about the immunological warfare that cells come out, they're fought off or not fought off develop endometriosis or not develop endometriosis. In women who don't have endometriosis, is there actual evidence of this immunological warfare going on? 90% of women don't have endometriosis, so there should be lots of evidence of this immunological warfare that's keeping, the cells from attaching. So, is there evidence of that going on?
Well, I think it's also the balance. I mean, like we've also talked about, that even the early insults, what clinicians describe as maybe endometriosis where you can't see or there is some kind of effect outside, that could be having an impact on the utopic endometrium. So is it possible, besides some of the other genetic alterations and the epigenetic changes we've seen, that there is something inherently different about the uteri of these women? And if they have occult disease, as it's known or termed, it's already starting to imprint changes in the endometrium itself. So perhaps those cells are escaping or have changed their phenotype to some extent, and they escape that immune surveillance. They can attach, they can grow, they can invade.
Well, is there evidence of the immune surveillance in women without endometriosis? I mean, how does that work? There's 90% of them that...
So, there are a few pieces of evidence several pieces of evidence that the endometrium of women with endo is different with respect to cytokines and pro-inflammatory mediators, prostaglandins, aromatase, so increased estrogen. But there's also, we have found, and we didn't present this data today, that there is a decrease in the number of uterine NK cells in the menstrual effluent of women with endometriosis. And uterine NK cells are those cells that take care of senescent cells, and they are very involved in immunosurveillance. So there's clearly a defect in that capacity in women with endometriosis.
What I'm interested in is there positive evidence of those NK cells killing reflux endometrium in the 90% of women who don't have endometriosis?
No. Not at this moment. There's no evidence for that. There's a great paper by Brighton and Brosens who described uterine NK cells as very important for removing the senescent cells that are involved in endometrial remodeling. And when that does not occur, they do not decidualize properly, and it's believed to promote uterine factor infertility in women with endometriosis. And they have some pretty compelling evidence in their paper, and I would point to that as, some evidence for that.
Two things are dominant in my mind. One is the frequency and the quantification of the material that escapes. If it is retrogradeness or effluent, that is different, that has properties to fight against and win the war in peritoneal battlefield. That quantification is more important because these women characteristically have heavy bleeding. They bleed tremendously. The menorrhagia is there. They have some uterine anomalies. They have arcuateness in the uterus. In one observations we have, we published this in a hysteroscopy book. We have like 300 cases. We looked at biopsy-proven endometriosis, early and advanced. 30% of them, their endometrium cavity had arcuateness, detectable on direct observation. And I think that's important. And also the damage on the peritoneum is more than we see. It's not only the lesion. We see the classically defined lesion, pigmented lesion, and non-pigmented lesion that Martin and Redwine for years, that early 90s until then has been defined so well. Since then, there's not a single article for 20 years how that really looks. I mean, according to classic definition, what they tried to do, every millimeter divided in thousands micron, about 200 micron, human eye at even less, we can see and we can detect endometriosis. It's true. They were right on that. In that group, for that definition, that is endometriosis, very little in that sense. even one or two, if you get it right, that's endometriosis. And on the other hand, there's a huge mass infiltrating, frozen to the sciatic nerve in volume, 1 kilogram of mass, exaggerating. That's endometriosis too. There's a huge difference, the amount of horsepower the nuclear genetic machine exerting on the way it goes, and the timeline it achieves that purpose is different from one person to another, and also the genetic power of that disease process is different. Many plays are going on here.
So I would like to ask Ozgi a question that follows up on a question I think I asked him 5 years ago when we first got involved in this, which is, how important are the particular cell subsets in the menstrual effluent, the menstrual blood that you put into the peritoneal cavity? And I was asking you about red cells. Are they really important to be there? And I think neutrophils, which are about half of the white cells that are in a menstrual effluent, are probably really important. Have you actually asked whether the lesions are more easy or harder to develop by depleting some of those elements?
So we haven't, but Thomas de Hoog did a really nice series of experiments in Kenya using the baboon model. So essentially what he did was he took the menstrual tissue just like we do and inoculated the animals. But if he started depleting, so centrifuging it out, just using only the menstrual, just the fluid, without any cells, those animals didn't get disease.
Okay.
They had to have the cells and the tissue to get the disease.
Right. But the question is, what cells? I mean,
cells?
can you just do stromal cells or just do epithelial cells?
So
Do you need the neutrophils at all to induce the lesions? That's basically my question.
And that's my aim in one of my R01, so I hope that I get it funded.
But, I mean, just one of the comments that I made towards the end in terms of at least using our genetically modified mice, it looks like with the epithelial cells that overexpress, at least in the context of N1 ICD and some of the other genes that we've been looking at, if they're specifically overexpressed in the epithelial cells, they tend to get a better
More
tail.
potent.
More potent.
Does it promote their survival?
Never looked at it. They just, I mean, you know,
Because that's what, I mean, in our specimens, we have very few epithelial cells, very, very few, but they die very, very quickly.
Yeah. So maybe they need to get into the peritoneal cavity in order to survive.
They need to attach to something,
They need special growth factors.
It seems like we're concluding the day. Are there any more questions?
There's one more in the back.
Hi, thanks. As a long-term sufferer, I would just like to say a big thank you to everyone who's doing some incredible work by the sounds of things. So it's given me faith as well that we are going somewhere. So thank you for that, because I think for a lot of us it's felt like we're not, but a lot of us aren't in these rooms. So I would like to say thank you to everyone who is doing something. A few kind of comments which will lead on to a question. It's the menstrual effluent you're talking about, and then we've obviously got the blood from lesions elsewhere. I'm presuming that they're both being studied in similar light. And today seemed very pelvic focused, but we're all in agreement that endometriosis is a body-wide disease, I hope. I'm 40, symptomatic since 14, 9 surgeries, Zoladex, hysterectomy, still symptomatic in all the ways that you were describing earlier, even though I have no womb anymore. So I'm just wondering if we are properly looking at things with regards to the body-wide aspect, because I've been saying to doctors for years, I feel like I am systemically inflamed. But to get that listened to has been really difficult, which is why I'm here, because I saw the heading, I was like, yes, finally, here we go, brilliant. But then we're also in the realms of how we are treated as patients and the system in various countries, and I'm talking about England, France, America, all over the place. We get dissected into different departments. So I'm seeing my gastroenterologist. I've got a high calprotectin. That's an inflammatory marker. I go with that to a gynae. He doesn't want to know. I go to a rheumatologist. She's like, yes, I'm looking at inflammation, but go back to your gastro about that. I have a certain examination with the gastro. He's like, well, I'm not going to look at your ovaries because I'm not a gynae. So I would just like to just put that out there really as comments to the Endometriosis Foundation of America and the world, that we've obviously got a long way to go, but it does fill me with confidence that there are conversations like this happening. So, and my main question, to get to that, sorry, was for the 200 million of us who hug hot water bottles and wear thermocare heat pads all the time, is there research being done into why heat helps? If not, why not?
I don't know if there's necessarily evidence into heat, but I actually am also 40 years old, just like you, and I've had endometriosis probably since I was 10. And I've had a very similar story to what you have had, and heat does help. And I've actually studied why it helps, and it's the same kind of idea that we have with the sympathetic nervous system. I think it's the same idea with the cold as well. You cycle between hot and cold if you sprain your ankle. So it's kind of the same idea to confuse some of the nerves, at least from what I've been able to understand. I'm sure there's much more specific nerve information that from one of our earlier speakers.
I would like to make a comment. You describe a lot of things in the body. I'm a poor clinical man. I think for everything there is an intelligence. There is a control. It's my belief that all that what you describe is controlled by the nerves. When you ask why the pain, this main area, is different than the pain in the abdomen, the pain is always the same. The pain is going up. It's an information going up to the brain. But when you have an irritation of the sympathetic nerve in the uterus, you will have also the irritation of the efferent fibers of the uterus. That means you will have the bleeding, you will have more pain in the uterus, you will have the dysfunction of the uterus, and so on. We saw your lecture, you said when we have no endometriosis, the patient, you use the word interstitial cystitis, ITSI. It's not an interstitial cystitis. It's an irritation of the nerve of the bladder. Yeah. And if you are right, you send the patient to a urologist, he will say, oh, you are bleeding from the bladder. You have an interstitial cystitis. So what we call adenomyosis is maybe interstitial cystitis by the urologist. And when you send the patient to a gastroenterologist, he will say, oh, you have an overactivity of the bowel. Sometimes you have some bleeding. And this one pathology. And just one comment, further comment of the nerves. All patients affected by endometriosis have something really of common. It's the stress. I was working 20 years in Germany, in Cologne. You know, in Europe, you have small cities, small countries. And I saw a lot of patients coming from Turkey. And this patient explained me, it's incredible what is going on in this country, in Germany. When I was in Turkey, I had no pain. Okay, we know about pollution, we know about coldness, there are all the risk factors for endometriosis. But you have pollution and coldness in Turkey in the same way as in Germany. But something changed externally in the life of this woman. They came to Germany and they have an increased stress level. And stress level, that means overactivity of the sympathetic nerve system. And my belief that the sympathetic nerve system will probably generate all this trouble. That means the endometriosis. Yeah. And and if I consider the patient with deep endometriosis, maybe you will agree with me. In my patient, most of the patients affected by deep endometriosis with bowel endometriosis are women who were born in a family where very, very frequently the mother wanted to get a boy and she got a woman. So it's the first fight. We know that endometriosis developed in the fetus. Maybe that was the first fight of the woman. I want to leave. then there are very frequently women working in the main world, in the world where they have to fight and to demonstrate every day, day after day, I'm here, I can do the same like you. That is stress too. So it's really my belief that the stress, the sympathetic nervous system, the autonomous nervous system, maybe control all these things. Thank you.
Thank you. It seems like the time is up there. Are there any more questions? Well, we were here today really to advance our knowledge and to help women with endometriosis, and among us to develop a language of communication. I really appreciate patients coming here, voicing their concern, because those of you who have the disease will never understand, I assure you. But we care. We do genuinely care. Look at these gentlemen, scientists and surgeons, and we see the disease differently. You could tell, even in the same profession, same section, for years they've been doing it, they don't have the same opinion about things. So you have to have empathy for us too. We don't have the answer. But I really appreciate you staying this long. I hope to see you tomorrow. We're starting at 8:30. It's going to be mainly surgery day. You can blast the surgeons and stump them. So it's going to be exciting tomorrow.